Tonight, we'll be hearing from Dr. Brock Lanier. He's a UCI Health plastic surgeon who specializes in aesthetic procedures, as well as microsurgery and reconstructive surgery for trauma and cancer patients, including breast and skin cancer. He's an assistant professor of plastic surgery at the UCI School of Medicine. He did his residency in general and plastic surgery and performed a fellowship at the National Cancer Institute in surgical oncology. Tonight, Dr. Lanier will speak about micro and macrosurgery and non-surgical treatments to include treatment of various types of skin cancer. Go ahead, Dr. Lanier.
Great. Well, first of all, thank you guys for having me. It's really a privilege to be here and nice to be able to talk with a group of non-physicians. Before we came on, I was saying that this is actually a more difficult talk to give than talking to a room full of facelift experts, for example, because generally you can anticipate with that audience what the discussion points and touch points will be. With the lay public, it becomes a little bit harder for me to predict what people are interested in, what they'll ask about. I try to run these presentations by friends who are not doctors, that are accountants or engineers, both to make sure the terminology I'm using is understandable, but also that the pictures aren't too graphic. So if you're someone with a queasy stomach, tonight there are not really any graphic intraoperative surgical pictures. Most of them are diagrams and cartoons, which actually makes it a little bit harder to put the talk together, but I think will be safe for everyone, hopefully to enjoy and will learn from. The title is Surgical and Non-Surgical Aesthetic Enhancements, and I purposefully crossed out cosmetic. Most plastic surgeons would say that they do aesthetic surgery to improve appearance. The term cosmetic tends to be something more reserved for makeup or some sort of non-surgical intervention. And typically it's used more by the lay providers than someone who's actually a trained plastic surgeon. So that's why I've kind of made the point of saying tonight's topic is going to be about surgical and non-surgical aesthetic enhancements. I don't have any financial disclosures, and we won't be talking about any particular products tonight. We might mention a couple of brand names, but no particular products. Now, if there's one thing I would tell anyone who's thinking about going and seeing a doctor about their appearance and thinking about an aesthetic procedure, either surgical or non-surgical, is the most important thing is find a board-certified plastic surgeon. Just having a medical license in California means you can do almost anything. So a family practitioner or OBGYN or head and neck surgeon can technically be licensed to do breast augmentation, even though they have no training in it. Plastic surgeons are really regulated by the American Board of Plastic Surgery. You can ask your doctor, and you can trust but verify if he or she is board certified by going to the website, and you just click, is your plastic surgeon board certified? That'll take you to a different screen where you can type in his or her name. So this is me. And then you click enter, and it basically tells you whether or not they are certified, or if the American Board of Plastic Surgery has never heard of that person. So this is me. I passed my test in 2019 when I finished training, and it says that I'm active and certified. A little bit about me, because I didn't know there was going to be an intro, but I was born and raised in Tennessee, in Memphis. I did medical school in Memphis at the University of Tennessee. And then I did general surgery training in DC at Georgetown University, and cancer surgery training at the National Cancer Institute, which is a great place. It's in the headlines nowadays for different reasons. For the infectious disease component, Dr. Fauci's office was actually down the hall from us there. So I remember seeing him walking down the hallway, and he used to have a very low-key role, which is interesting nowadays how he's very nationally prominent and recognized. After the general surgery and cancer surgery training, I came to USC and did my plastic surgery training, and then actually went to Stanford and did advanced reconstruction and microsurgery training before coming and starting practice at UCI. So that is my background. a lot of people who aren't doctors, and even some doctors, a lot of doctors actually, don't understand what plastic surgery is or what plastic surgeons do. So the way I try to explain it is actually Spain, where I lived for a few years, is what most people don't realize is that there are 5 official languages spoken in Spain. And most people can name Spanish. That's the obvious one. The other 4, which means most people have never heard of, is Galician, which is in Galicia. The Basque Country speaks Basque. Catalonia speaks Catalan. And Valencia actually speaks Valencian. And these are all distinct languages, as separate from each other as French is from Italian. And back in the pre-COVID days when we could travel, if you landed in Barcelona at the airport, this is a sign you would see, which is the top line is in Catalan, the second line is in English, kind of the international language, and the bottom line is in Spanish. And they do that for a reason in Catalonia, to drive home that point that their language is distinct and above Spanish. I wanted to make that point because a lot of what I do is not aesthetics. Probably half of what I do is reconstructive. So I felt like it would be a little bit of, it could be a little misleading to just come in and talk about aesthetic surgery and associate that with plastic surgery. But the 5 areas of plastic surgery, most people don't know about, but when you hear about it, it makes sense, is the obvious one, aesthetic surgery, which we'll talk about tonight. The other areas, reconstructive surgery, which include things like cancer reconstruction, trauma reconstruction. This is about half of my practice. Craniofacial surgery, things like cleft lips and cleft palates in children. Hand surgery, which might be surprising, but you think about the delicate parts of the hand, and plastic surgeons are actually obvious people who would do this type of surgery. We share hand surgery with orthopedic surgery. Things in hand surgery are congenital deformities, carpal tunnel syndrome, broken fingers or wrist, and finger replantation. And I can tell you, during COVID, a lot of people have been home doing home improvement projects, working with circular saws. And just about one Saturday every month, I've been putting a finger back on that's been cut off. The final of the 5th areas is actually burn surgery. Plastic surgeons take care of both people just after they've been burned, so acute burn patients, and also people that have recovered from the acute burn and have chronic deformities. So one thing I would point out, if you take cleft lip and congenital deformities of the hand and burn surgery, that's essentially the Shriners Hospital where we work, which is a great organization. But that's a very different experience from a plastic surgeon who does and focuses on aesthetic surgery. So you can see that plastic surgery is actually a very varied field. There are plastic surgeons that never do a facelift, and there are plastic surgeons that only do facelifts. So I just wanted to throw that out there because the rest of the night we'll dive into aesthetic surgery. And I didn't want to reinforce a stereotype without sharing what all plastic surgery is. If there's one key point in talking about aesthetics of the face, it's that it's important to know that your overall health directly affects your skin. Things that are unhealthy like obesity and malnutrition, diabetes, smoking, sun exposure, these are really the key things to control before you move forward with anything else. And the next thing after that would be a skincare regimen, and we'll talk about this. And it's really after you've established these elements that you move on to things like neuromodulators. This is Botox, for example, to control wrinkles, or surgical options. And then in between, you have all kinds of things, such as fillers and resurfacing treatments like chemical peels and lasers. So we'll break this down a little bit. I had one professor who used to say that just jumping to the facelift or the fancy expensive procedure and not taking care of the patient's overall health is a little bit like painting the front of the house while the back of the house is on fire. Meaning you can go and do something invasive, expensive, requires recovery time, and the result will not be optimal or what the patient wants, or it won't last because of comorbidities such as ongoing smoking. So it's important to take care of these elements before moving on. Now, obesity, very prominent in the United States. About 1 in every 3 Americans is obese. And this is not really an aesthetic problem. Obesity directly decreases someone's life expectancy. So it's really a health and longevity issue. For a woman who's a non-smoker, if you compare her to her counterpart who's obese, their life expectancy is 7 years different, from 86 years to 79 years. And these are statistics, but 7 years is a long time of life. You know, there are chemotherapies and expensive medications that people give and take just to prolong life 6 years, or 6 months rather. So if you can get someone's obesity under control, you can really extend their life in a very meaningful way. And obesity impacts health really just as much as smoking. Now, smoking, on the other hand, is actually going down in the United States, which is great. 1 in 6 Americans smoke, and that number has generally been decreasing over time. You might say, well, what does smoking really do to your health? Well, it's bad, and your skin in particular. So there are twin studies out there where they look at twin sisters, in this case, 2 52-year-old sisters. The top sister has been a heavy smoker, 2 packs per day, for over 2 decades, and compare her to her twin sister who's never touched a cigarette. And it's pretty obvious the impact that smoking has on your appearance and your skin's health. If you're going to do a procedure, it also directly impacts your ability to heal from the procedure and your chance of having a complication. The other thing to keep in mind, especially in sunny parts of the country like California, is that sun exposure damages skin. The sun does a lot of things on a cellular level that compromises the skin's ability to remain healthy. And I wasn't going to run through all of these different parts, but essentially sun exposure causes skin aging. It does things like cause wrinkles, loose skin, uneven or discolored skin, and skin cancers. None of these things are good for someone considering an aesthetic procedure. Skin cancers are things like melanoma, which is fortunately the least common type of skin cancer, but it's the most deadly. So the warning signs, I'll take 30 seconds to talk about the warning signs of melanoma, is a pigmented spot that looks asymmetric. The border is irregular. It has multiple colors. Some areas are lighter, other areas are darker, and the diameter is large. If you remember when people used to use number 2 pencils, 6 millimeters or 1/4 of an inch is about the size of an eraser on a number 2 pencil. And if you notice the spot changing in any way, you should probably talk to your doctor, dermatologist, a plastic surgeon, really any healthcare provider to get it looked at. Now, we have known for a long time that sunscreen use prevents some types of skin cancer, and squamous cell carcinoma is the most common type of skin cancer, but not the most deadly. Melanoma is the most deadly. So we didn't have proof for a while what the impact of sunscreen use was until the study in Australia, where in 1992, researchers randomly took a town and divided it in half. And half the town, they took sunscreen and gave it to the people. It was only SPF 16 and said, use the sunscreen. They didn't command people. There weren't a lot of routine checks to see if people were using sunscreen. They just encouraged people to wear it, and they gave it to people for free. The other half of the town, they didn't do anything to them. They said, keep doing whatever you've been doing. The pre-existing thought before this experiment was that it would take a long time to see an impact. Both groups were followed for skin cancer development. And what ended up happening is within about 5 years, there's a clear divergence of the number of melanomas that form in the normal people, the people that did not wear sunscreen every day, versus the people that did. So 10 years after starting the experiment, the people who were normal, quote unquote, not wearing sunscreen had 22 melanomas. And the sunscreen group had 11, meaning their risk of melanoma was cut in half. And again, this was only using SPF 16. If you also drill down the types of melanomas people got, The sunscreen group had early melanomas, which are less dangerous. The other group with no sunscreen, about a quarter of the melanomas, 5 of the 22, were deeper melanomas, which are more dangerous. So the conclusion is you really should wear sunscreen every day. And I tell a lot of people this because I am kind of an evangelical for sunscreen use. And they say, you know, I'm old or it doesn't matter. And really what I would point out from this graph that I showed earlier is that if you are planning to live longer than 5 years, then it's worth wearing sunscreen because you will have fewer skin cancers and you will come see a surgeon like me a lot less. And I don't have any kids to put through college, so I'm okay if people don't come see me, if it's preventable. Some people don't really respond to numbers and graphs and that type of argument, so this is my alternative. There's an app available in the App Store, Sunface. You can type it in, download the app. What it does is it lets you take a selfie. People love taking selfies these days. And then you can dial in 5 years into the future, 10 years into the future, and see what you would look like if you wear sunscreen every day, or if you don't wear any sunscreen. And you can project this out 25 years. And they even have an option to see what you would look like if you tan every day for the next 25 years. The differences a lot of times can be convincing. So this is someone who works in our office and what she'd look like in 25 years with sun protection versus without sun protection versus if she were to tan on a weekly basis. Tanning is essentially accelerated sun exposure. So I would encourage everyone, wear your sunscreen. There can't be a more stringent evangelical than me for wearing sunscreen every day. I usually am up about 4:30 in the morning, and I leave for work about 5 in the morning, and I've already put sunscreen on before the sun comes up. After establishing healthy habits, the next step is a good skincare regimen. So this is kind of the gateway before moving on to other things. There's a lot of products out there, and I'm not going to talk about any particular commercial product. There's 2 things to know, essentially, 2 important things to know if you're thinking about a skincare regimen. One is vitamin A products are basically universally good for skin health. They come in 2 formats. One is a retinol, which is a natural form of vitamin A. And when you put it on as an ointment or a cream, it's converted to retinoic acid, which is the active form. The other way you can get it is to buy tretinoin, which is retinoic acid. It's a synthetic form of vitamin A, so it's more potent. The tretinoin is prescription strength. The retinol is over the counter that you can get at Walmart or Walgreens or Sam's Club or Amazon. And these things essentially do a lot of things to help your skin, such as stimulate collagen production, improve blood flow to the skin, exfoliates the skin, does a lot of good things for the skin. But essentially they decrease skin pigmentation, they increase collagen, and they decrease wrinkles. These are things that basically everyone wants. So number 1, I would say that your skincare regimen in some form typically should include a vitamin A product. The other thing, other than a vitamin A product, is a hydroquinone. And essentially what hydroquinone does, it's another topical ointment that you put on. It blocks an enzyme that's necessary for pigment production, or melanin. Melanin is pigment in the skin. And so it blocks pigment formation in the skin, and it has great effects such as preventing rebound pigmentation if you go on and do a chemical peel or laser treatment. But even if you don't do those things, hydroquinone decreases skin pigmentation, it brightens the skin, and it provides for a more even complexion. So the ideal skin product line should include those 2 things because those are the 2 most basic elements that are supported by science. The skincare line should be comprehensive and suitable for all skin types and adaptable for everyone's goals and needs. There's a ton of products out there. I'm not going to go into any of them. There's both over-the-counter products that you can buy on your own that are relatively cheap. There are over-the-counter products that are expensive, and vice versa for prescription strength products. So I would just say if you're interested in starting a skincare regimen, talk to a plastic surgeon would be a good stop, and talk about your individual needs and your limitations and goals, because some people don't have any cost restraints. Some people are on a very limited budget. It's just everyone is very, very different, but there's something out there for everyone. I can pause here a second if there's any questions. This is a great jumping off place. But essentially, this is what you want to do. Take care of your health, get on a good skincare regimen, and then you jump off into the more interesting things, which are really the meat of this talk, both the non-surgical and surgical parts of aesthetic care. Facial aesthetic options can vary both by area of the face, and we divide it up in the lower, mid face, and upper face, or by age. In the upper face, there are things like neuromodulators, and this is things like Botox. We call them neuromodulators because essentially what the chemical injection does is it blocks the nerve's transmission to the muscle. And if the muscle isn't contracting, you get fewer wrinkles. The effect is temporary. Most of the products out on the market last about 3 to 4 months. That makes some people happy because they know it's temporary. Other people, they wish it lasts longer because they would come less frequently and spend less money. So, again, I guess the pros and cons are in the beholder, so to speak. Things you can consider for the upper face are lifting the brow or the forehead, an eyelid lift or hair transplant. In the mid face, neuromodulators are used for wrinkles around the eyes. Fillers are used below the eye and in the cheek. Some patients are interested in facelifts or rhinoplasties, or what people call nose job. And there's ear surgery, both for people with prominent ears, where their ears protrude abnormally. And you could think of President Obama, because he technically has prominent ears, or people with other ear deformities. In the lower face, neuromodulators are used to ameliorate wrinkles around the mouth, fillers around the mouth and in the lips. You can have jaw surgery, which is a genioplasty, which changes the chin's appearance, and we'll talk about that at the end of the talk tonight, or a neck lift, which can be done as part of a facelift. And then overall, for the whole face, there are resurfacing options, meaning you're going to exfoliate or rejuvenate the skin of the entire face. This is typically done with chemical peels or lasers. If you break it down by age group, generally the younger folks in their 20s and 30s are interested in things that change the shape of the face. So the rhinoplasty or nose job changes the shape of the nose. Genioplasty is changing the shape of the chin. And same thing for ear surgery. If someone is born with very prominent ears, some people are self-conscious about that and want the ears essentially tucked back in a normal projection from the skull. Some patients do resurfacing type procedures like the peels or the lasers. People who are in their 40s and 50s, they tend to be interested in different things like an upper eyelid lift, hair transplant, and some people, especially people who don't wear sunscreen, are interested in a facelift. The older crowd, and I say that, 60s or above, they tend to be interested in different things than people in their 20s or 30s. And these are things like neuromodulators, fillers, resurfacing options, brow lifts, eyelid lifts, both upper and lower eyelid lifts, and then facelifts and neck lifts. So I figured this would be a good jumping off point to talk about the neuromodulators. And what they do is they decrease, or if you're younger, prevent the appearance of wrinkles. It's officially approved by the FDA to treat wrinkle lines of the forehead, between the eyes, and the crow's feet, which are the outside part of the eyes. But people use it for a lot of different things, not just things that are FDA approved. So who's it for? Almost anyone wanting fewer wrinkles, which is most people. There are a few exceptions, such as pregnant people, if you have a skin infection, if you're allergic to the products, or certain neurologic conditions, such as multiple sclerosis. In general, the neuromodulators, like I said, last about 3 or 4 months. So it's a temporary effect. And then you would need a repeat injection. Fillers come in different shapes and sizes. They're officially approved by the FDA for adding volume to either hide wrinkle lines or increase facial features. And common places where it's injected are the lips, cheeks, nose, or under eye. So depressions underneath your eye. All fillers are temporary or absorbable except one. And that one is essentially a type of cement. And that's really this PMMA is the only permanent filler. Most people don't use it. The other permanent filler that's not technically a product because it comes out of the patient is a fat injection. So we can harvest fat from places that maybe have excess fat like the abdomen and use that to inject it in places like the cheeks or the lips. The most common filler by far is something called HA, which is hyaluronic acid. Hyaluronic acid. And what it is a naturally occurring product that essentially is the spongy part underneath our skin. Hyaluronic acid is identical in all animals. So it's something that through the development of all animals and people has been conserved. And so the implication for that is if there's something that universally occurs in all people and animals, like water, for example, it tends to not be something that induces allergies or causes allergic reactions. It tends to be a very safe and inert product to use. So that's why it's by far the most popular filler these days. There's a lot of different brand names out there that are different types of hyaluronic acid. So who are fillers for? Technically, almost anyone who wants to either achieve fewer wrinkle lines or increase certain features of their face. There are risks associated with fillers. They have more risks than Botox or one of the neuromodulators in that they can cause redness, rosacea, swelling, infection. If you inject into a blood vessel, that can kill the skin where the blood vessel feeds. And in very, very rare instances where people inject fillers in dangerous areas, it can actually induce blindness because the filler accidentally travels into the eye. Fortunately, that's a very rare occurrence. Resurfacing. These are typically things like chemical peels or lasers. There are other modalities or machines such as dermabrasion, radiofrequency remodeling, ultrasound remodeling, but the idea is all the same. You use some sort of energy source or a chemical reaction to exfoliate the skin. The benefits is that it improves sun damage that the skin's accumulated over time. It reduces discoloration. It improves your skin texture and restores a more youthful complexion. So who's it for? Almost anyone desiring wrinkle line treatment. The pre-treatment musts are things like a topical vitamin A, the retinoic acid, hydroquinone, and sun protection. Because when you exfoliate the skin or take off the top layer of the skin, you will be more susceptible to getting rebound redness and discoloration, and you will be more sensitive to the sun. So before anyone undergoes one of these procedures, those basic tenets of a skincare regimen are musts. A lot of people ask about chemical peels versus lasers, and they're fairly similar, but they have pluses and minuses. There's less skin thinning with peels. Peels tend to be cheaper overall. Peels are more effective at treating deep wrinkles, but there's certain downsides. Redness tends to last longer with peels after you do them. There's more swelling overall. And there's different types of peels. So there's light peels, which can be repeated without scarring and with really minimal redness, but you get less of an effect. Deeper peels, you get more of an effect, but they take longer to heal. You can have redness for longer periods of time. And there's a higher risk of things like decreased pigmentation of the skin and scarring, abnormal decreased pigmentation of the skin and scarring. So those are kind of the basics of the non-surgical options, which are the neuromodulators, fillers, and then all the different resurfacing options. And then you kind of move into surgery. And you might say, well, why would you do surgery versus one of those non-surgical options? Because surgery is going to be more expensive. It's obviously more invasive. There are cuts and scars involved, and it takes longer to heal. Well, the main advantage of surgery is it can deliver a bigger impact than those other aesthetic tools. And all the different surgical options are the things we mentioned earlier, and we'll touch on the highlights now. The big one that gets a lot of press attention is a facelift. And the other technical term for this is a rhytidectomy. A rhytid is just a fancy term for a wrinkle. So a rhytid and a wrinkle are synonyms, and an ectomy is removal. So facelift is a little bit of a misnomer because we're taking out extra skin and leaving behind skin that is less wrinkled. The indications for a facelift is it improves the signs of aging in the face and the neck. Candidates are people who are overall healthy, they don't have major medical conditions that impair healing, people who are non-smokers, and people who have a positive outlook and realistic expectation. It's important to talk with people and let them know that decreasing the amount of skin on your face, tightening the skin, which is what a facelift is, will not make you look like a different person or make you look like your favorite celebrity. And some people actually come in wanting to look like a celebrity, and you will look like you. You will just like a younger version of you. Risks are multiple. They're usually not very frequent, but you can get bad scarring, pain afterwards, numbness, weakness of facial muscles, or poor wound healing or skin loss, especially in people who are smokers, who have uncontrolled diabetes, or other risk factors for wound healing. The recovery after a facelift, typically patients will spend one night in an aftercare facility, which is something like a nice hotel that has nurses available to help patients. Most people need to lay low, have a downtime of 3 to 7 days, and the incisions are usually healed in 2 to 3 weeks where people can get back to their normal activities. Swelling can persist up to 6 months. So the way a facelift is performed using cartoons, because I promise no graphic photos, is typically the incision starts in the hair and goes along the front of the ear where there's a natural wrinkle and you can hide the scar, and then goes behind the ear. And at that point, you're going to lift up the skin of the face and basically peel up part of the skin of the face. Now, the facelift and how invasive it is depends on how far you undermine or lift up the skin. Some people want a more moderate effect, or they just want the cheeks elevated and a little bit of the neck. Other people have more wrinkles, have want a greater effect. And so you can actually go down through these incisions that go around the ears and tunnel all the way down over the majority of the face and into the neck, and do a facelift and a neck lift at the same time. If there's extra fat or fullness under the chin, a separate incision is made in the chin, and liposuction or direct fat removal can be performed at that time. Afterwards, the skin is pulled usually up and back and then trimmed and inset. So you might say, well, that sounds very simple and straightforward. Conceptually, it is, but as you can imagine, there's a lot of valuable real estate in the face. So there are major sensory nerves all over the face. There's multiple motor nerves. These generally come out in an area below and in front of the ear, and then perforate through the different layers of the face to provide the muscles of the forehead, eye, cheek, mouth, and neck. And so there's 5 major motor branches that we all learn about in plastic surgery school, and you have to know where these are. But not just that, the face has various levels or strength layers, and they create what is conceptually an onion. And these nerves and blood vessels move through these different layers, going deeper and coming closer to the skin. So the trick is having a very detailed knowledge of the anatomy in order to be able to navigate in a 3D and systematic manner around these critical structures. This illustration is of a side view of the face, and this nerve is the major motor nerve I pointed out. And you can see how it starts out very deep next to one of the muscles that helps you chew, and it perforates through or comes up in a more superficial or closer to the skin in a certain place. And this is a very easy one to get if you are sloppy or new starting out. So this sort of detailed anatomy is absolutely essential to be able to do a facelift safely. I would say that we use these same principles in other areas of plastic surgery, such as reconstruction and pediatric surgery. So if someone takes a force to the eye, usually the bone that's most commonly broken is the bottom of the eye socket. So you can imagine getting into the eye socket to repair this bone takes a little bit of anatomic knowledge and finesse in order to get in there without damaging the eye. So it's plastic surgery, I think of as like a toolbox, and you can apply it in a lot of different ways, both in the aesthetic sense or in the reconstructive sense. So that's a facelift. And like I said, if there's questions, everyone shout out. They said they would unmute and ask me the questions. But I'm going to keep moving forward because I don't want to take up everyone's entire night. The next surgery we're going to talk about is an eyelid lift, or what's technically called a blepharoplasty. And the indication for this is it improves loose or sagging skin or folds that disturb the natural contour of the eyelid. And sometimes, many times, these folds can impair people's vision. It can address fatty deposits that cause puffiness, bags under the eyes. It can address drooping of the eyelids and excess skin and wrinkles in the lower eyelids. Candidates are the same as before for the facelift. That'll be a common motif for most of the procedures tonight. Risk, the major risk is dry eye. Usually this is temporary when the eye is healing. But if you have certain risk factors, dry eye can be permanent and it can be very bothersome. There's might be people out there with dry eye symptoms that have to use drops frequently, and blepharoplasty can make this worse. Swelling, bruising, and bleeding will happen. Usually they're very temporary. Scarring is usually not a problem, but when it is, can cause significant problems that need to be addressed with additional surgery. Eyelid weakness and trouble closing the eyes, again, an infrequent but very bothersome risk. So a lot of these things don't happen very often, but when they do, they can be real trouble. And so it's one of those things where an ounce of prevention is worth a pound of cure. Recovery is generally faster than a facelift. You don't need to go to an aftercare facility. You usually need to lay low about 3 to 5 days. The bruising and swelling usually go away in 2 to 3 weeks, but sometimes swelling can persist up to 1 to 2 months. The way a blepharoplasty is performed is the extra skin is outlined and then excised in this kind of curving ellipse shape in the upper lid and then closed, and the scar is hidden in the natural skin crease that people have in their eyelids. This is an example of someone who had upper lid blepharoplasty. She also had weakness of the muscle, which is the levator muscle in the eyelid. And that's why her eyelids look low. She looks sleepy. People complain they look sleepy because as people age, their muscles actually can tear off or weaken, and they have an inability to open their eyes totally. So if you know anyone or have a friend where their eyelid is actually impinging upon the black part of the eye here, that is abnormal. And this is actually not an aesthetic problem. This impairs people's vision. And generally speaking, insurance will cover blepharoplasties if they're indicated to fix or correct impaired vision versus someone just wanting to look better. But this is an effect that you can get after a blepharoplasty where you've repaired where the muscle inserts on the eyelid and taken care of the extra skin the patient has. And you can note the natural position of the upper eyelid is above the black part, the pupil of the eye. There's also lower lid blepharoplasties. This is a side view of the eye. And if you weren't really well trained, what most people would do to get into the puffy part of the fat is go straight to it. And you would transect through skin and fat. And this is the muscle that lets you open and close your eye in cross section, and then enter different strength layers and finally get to the fat. So if you just went straight in, you would go through 4 or 5 layers of the eye. Having a more detailed knowledge of the eye, what most surgeons do is actually make an incision on the inside part of the eyelid that lets you transect really one layer and get into where people want the puffiness and the fat removed. And so again, having some advanced detailed knowledge of the anatomy helps you preserve eye function and decrease some of these risks such as eyelid weakness, trouble closing the eyes, etc. This is an example of a lady who had a lower lid blepharoplasty, and this is what she looked like 5 years later. So the results can last a long period of time, and you'll notice the hollowing and the bagginess and poofiness under her eyes are corrected. The next thing I'll talk about is a brow lift. This is when you lift the forehead, and the indication for doing this is reducing the horizontal lines that form across the forehead and the bridge of the nose. It improves frown lines and the vertical creases of the eyebrows. It raises sagging eyebrows that are hooding over the eyelid, and it places the eyebrows in a more alert and youthful position. Candidates, these are the same criteria as before. And the risk are things like scarring, hair loss around the scars. It will raise your hairline. Eye irritation and dryness can happen. Numbness over the forehead can result, but is usually temporary. And then poor wound healing and skin loss can happen. Again, this is more common in people with risks such as smoking. Recovery, most patients go home same day. It's outpatient surgery. They usually need to lay low about 7 to 10 days. And the incisions have usually healed in about 1.5 to 2 weeks. But swelling can persist up to 1.5 to 2 months. The way the modern brow lift is performed is by making 5 incisions along the hairline to hide the scars. And then using an endoscope, which is sort of like a little camera and robot arms, you go in and lift the muscles and the soft tissues that make up the forehead and lift it higher. And then there are ways to fixate it with sutures and other devices to keep it from slipping back down. This can be both an aesthetic procedure or, like with the eyelid lift, it can actually help improve someone's vision. So I go to the VA hospital in Long Beach 1 day each week. And one of the more common things we do for the vets there, especially the older population, are things like brow lifts and eyelid surgery. And it's not ever done for an aesthetic or cosmetic reason, but it's because these problems can actually significantly impair people's vision. And so it's really a great service. You can do a surgery that lasts an hour, hour and a half, and dramatically improve someone's vision. And it's a very fulfilling service to offer the vets. This is an example of someone who had a brow lift with the endoscope or the robot arms, as well as an upper lid lift and a lower lid lift. So all of these procedures can be combined if indicated. So, it's never chocolate or vanilla. It sometimes can be a mix of both. But this is the type of improvement that you can get by restoring the brow's position and then addressing both the upper and lower eyelid. Rhinoplasty or nose jobs, that's another very common thing that gets a lot of press. The indication for this is improving someone's nose size or shape in relation to the face. The other reason, or a combination, is breathing difficulties. If someone's been hit in the face and the septum, or the dividing part of the nose, has been broken and pushed over to one side, it can significantly impair someone's breathing. So there's a number of other indications for rhinoplasty, but most of them have to do with either correcting the septum or division of the nose or adjusting some part of the nose. Candidates, these are the same indications as before. Some people younger kids, 12, 14, 15-year-olds, want to get their nose fixed, most people would say, wait. Most board certified plastic surgeons would say, no children. You want to wait until the face has finished growing. So most people will not offer patients a rhinoplasty until they're at least 18 or 19 years old or older. Risks: difficulty breathing, usually that's swelling and temporary. Persistent swelling or scarring can occur. Pain or numbness. Infection is not a high risk, but it's a possible risk. An unsatisfactory aesthetic outcome is possible. And some patients need revision, especially if they've gone to someone who doesn't have a lot of experience doing rhinoplasty. Recovery: most patients go home same day. They usually need to lay low about 7 to 10 days. The incision is usually healed in 2 to 3 weeks, but swelling in the nose, if you've ever been punched in the nose, can last a long time, up to 9 to 12 months. So I typically warn patients who are thinking about a rhinoplasty that you have to wait at least 9 months before you see the final result. The swelling will go down quite a bit at first, but that little bit of swelling that's left persists a long time, up to 9 to 12 months. Rhinoplasties can be done a couple of different ways. The more traditional way is an open rhinoplasty. And what that means is you're making a cut on the inside of the nose that then goes across the bottom part of the nose, what's called the columella, and then into the other side of the nose. And what that lets you do is access the interior parts of the nose. The structure of the nose, or the nose's skeleton, is composed of lower cartilages. This is the tip of the nose. A middle cartilage, or an upper cartilage is what it's called, and then bone up at where the nose meets the eyes. There's a lot of different things you can do once you get into the nose to reshape it. A lot of times we'll take cartilage either from inside the nose, the septum, or the ears, or sometimes the ribs. We'll make an incision on the chest and take cartilage out of the ribs and use that to construct different grafts or struts. Essentially, this is like woodworking class, but with cartilage. And so you can use these struts to either increase the projection of the nose. You can shave down elements of the cartilage to decrease the projection of the nose. There's a lot of different things you can do. Put sutures in to manipulate these cartilages, add different cartilages in ways to increase the projection. So it just gives you a lot of options once you've opened the nose or peeled back the skin over the nose. The other thing you can do to change the shape is make cuts on the bones on each side of the nose. And this lets you manipulate the bones and then they'll heal in the new shape. But there's a lot of different ways to make these bone cuts. So this is someone who came in before a rhinoplasty, displeased with both the wide or bulbous aspect of his tip, and you can see his nasal tip is drooping, and a lot of people don't like a prominent top part of the nose, or what we call the dorsum of the nose. So having all this anatomic knowledge, you can make a blueprint or game plan for what you're going to do when you open the nose to shave down part of the top, put in grafts to straighten the nose on each side of it, put in a strut on the bottom to straighten the tip, and a cap to refine the tip of the nose. And so doing that, you can get outcomes with a more refined tip, a straighter nose, and one where the tip has been lifted and the straight spine or dorsum of the nose has been corrected. And this is a bottom view. Most people don't see people from this view, but I point out this is the scar that's visible, and that the scar is made on the inside part of the nostril, and then again comes across the bottom and then goes on the inside part. And that basically lets you lift the skin of the nose up like you open the hood of a car. This is another patient, her pre-op photos on the left and her post-op photo on the right, who had a similar rhinoplasty. You can appreciate the hump that a lot of patients don't like, and that's been reduced. So that's what an open rhinoplasty is. This is, again, the bottom view of the patient. You can see her scar here. I try to point out scars to all the patients ahead of time. The other way to do a rhinoplasty is to just make cuts on the inside of the nose without any communicating cut on the outside. This is called a closed rhinoplasty. There's less cuts and scars, but there's also less access. So this is one of the few surgical photos that I'll include. But essentially, you have a small access point on the inside of the nose that you can do things like shave down the dorsum of the nose if that's what the patient wants. So not all rhinoplasties are the same, but the closed, you get a quicker healing. You'll still get swelling and edema, but you have to be a little bit more facile, and you can maybe not accomplish quite as much as you may need to in the open versus closed technique. So there's a couple different ways to skin the cat, so to speak, here. The final thing I was going to touch on tonight before I finish is something called a genioplasty, and that's a chin augmentation, essentially. The indication for doing this is to improve the size and shape of the chin in relation to the face. And you can do this by either putting in an implant to make the chin more prominent, or you can make a cut in the bone and move the bone of the chin forward or back. Candidates are the same as before. Risks include things like pain and numbness, infection, especially if an implant is used, or an unsatisfactory aesthetic appearance. Recovery, everyone goes home the same day. It's outpatient surgery. Downtime is usually 3 to 5 days. Incisions usually heal in about a week, and swelling can persist up to 1 to 2 weeks. So recovery is relatively quick compared to things like a facelift or, a rhinoplasty. The way this is performed is a cut is made on the inside of the mouth. That gives you access to the bone, because essentially you make a cut and go in and peel up the soft tissues of the mouth. And that's how we pop the hood of the car, so to speak. If you're making a cut in the bone, it's usually a sideways or oblique cut, and the bone can be moved forward or back. This is a sliding genioplasty. And then these are plates and screws, similar to what we use when someone gets a broken face from a car crash, that we use to fixate the bone or keep it in place while the bone then heals. The other way to do a genioplasty is to put in a silicone implant. And these are different sizes and shapes, but essentially you make that same incision and go in and lift up the soft tissues off the chin and insert the implant. This is an example of someone who had a genioplasty, and then my presentation will be done. So you can see she had a sliding genioplasty, or a cut made in the bones of the chin, as well as some liposuction done to take out some of the fullness of her chin. And you can see the before and after. Usually with these, the side view is the most impressive. So you can see that moving the chin forward kind of puts her face in more of a balance, and decreasing the bulk under her chin also gave her a more defined, aesthetically pleasing appearance of the chin into the neck. And so my summary slides, 1, I would say use a board certified plastic surgeon. 2, maintaining your overall health is the single most important aspect of maintaining skin health and appearance. 3, a consistent skincare regimen, especially using sunscreen, is the foundation of any aesthetic procedure. And I would say be an individual. There are lots of options available if you're interested or if you have a concern. There's minimally invasive options and extremely invasive options. There are surgeries with very little risk or procedures with very little risk, and there are those with a lot more risk. And all of these options range from relatively cheap to very expensive. So I would say be informed. Don't let anyone rush you into anything. Ask questions and really feel comfortable with your plan, that whatever plan you're embarking on addresses the concerns you have. And it's not uncommon, and I would encourage people, if they have any doubts, to get a second or third opinion you really shouldn't rush into any of this.
A chat question. What strength do you recommend for sunblock? And do you know of a sunscreen that does not burn your eyes?
There are some formulations. They're usually the ones, I'll address the burning the eye part. The kid-friendly sunscreens tend to have less noxious chemicals in them that make them more kid-friendly. So those tend to not burn your eyes as much. Some of the others that I personally think, there's no real science here, but the zinc oxide, the barrier type of sunscreens, the way they absorb, they tend to run less. So if you then get wet or get in the pool, I think there's less running in your eyes as well. So I would recommend, if that's a problem, one of the pediatric type of sunscreens, because they're kinder and gentler, or one of the zinc oxides or barrier sunscreens. Now, the strength really doesn't matter. Usually the stronger ones, the SPF 100, are more expensive than the SPF 50, for example. But the strength really doesn't matter, because any strength is really great. You know, a low SPF 20 gives you amazing protection. The SPF 100 is sort of like overkill. You know, you don't necessarily have to have a nuclear weapon every time you fight a war. You know, sometimes just any weapon will do. And that's definitely the case with sunscreen, because like I said, the SPF 20 gives you 20 times the protection that you would have not wearing any sunscreen whatsoever. So any sunscreen, even the weak, quote unquote, SPF 15 or 20, is way more powerful if you wear it consistently than just putting on the SPF 100 one day a week.
I'd like to add my own follow-up question. How often should you reapply?
It's a great question. Generally, if you're outside and you're wet or sweaty, you'd want to reapply the sunscreen every 2 to 3 hours. If you're inside in like an office setting or walking between buildings, usually what I'll do is reapply it once or twice a day. So I'll put it on in the morning, like I said, before I go to work. Usually around lunchtime, I'll put on another time, the sunscreen. And if I'm gonna go outside like at 5 or 6 o'clock and it's in the summer and the sun's not gonna go down until 8 or 8:30, I'll reapply it a third time that day. So it really depends, you know, how late the sun stays out, and then are you getting wet, or are you doing something active like riding a bicycle where you're sweaty? So in those extreme examples of swimming, diving, sweating a whole lot, a good rule of thumb is every 2 to 3 hours reapplying.
I'd like to thank you, Dr. Lanier, for being here tonight and speaking with us. It's been very,
absolutely,
very informative. So thank you. And
absolutely. Thank you guys for having me. It was really fun.
yeah.